before we begin, I just have a few disclaimers. So just as a general disclaimer, this presentation is strictly created for educational purposes only and should not be substituted as professional advice. We will not be diving into any trauma-related topics during this time. As a signs and symptoms disclaimer, while learning about these conditions, it is normal to believe that you may show signs and symptoms related to the topic. We will not be discussing specific diagnostic criteria, so please do not self-diagnose yourself during this time. Please consult with a medical professional if you believe you may have something we have talked about today. As a resources disclaimer, a QR code will be shown at the end of this presentation, and I highly suggest that we all scan the code and fill out the quick form, and this will allow you to access extra information on what we discussed about today, and international resources will also be included in that email. So the first thing we're going to talk about is anxiety disorders. Now, anxiety does not necessarily mean stress, and stress does not necessarily mean fear. They're different things that mean different things. So stress is a normal reaction to a perceived event and will typically decrease once a stressful event has subsided. Anxiety is an intense irrational fear and anxiety towards perceived events persists even after the event has subsided. And this anxiety significantly and negatively affects normal functioning. Now, fear, on the other hand, is described as an intense, anxious reaction to a specific observable danger. So the danger is present, it's during the time that you're having this anxiety, so it's like right then and there. So disorders in this category include generalized anxiety disorder, social anxiety disorder, panic disorder, specific phobia, agoraphobia, separation anxiety disorder, and selective mutism. So depressive disorders are the next thing we're going to talk about. And again, depression does not necessarily mean sadness. Like, it does mean sadness, but in fact, it does not encompass all the symptoms one may experience in depression. So sadness is a temporary feeling of dread and hopelessness, but will typically subside in a few minutes. Depressive disorders are characterized by extreme sadness, hopelessness, lethargic symptoms, and a loss in pleasurable stimuli. That must last for at least 2 weeks at a time. So it's different than just being sad, you know? So disorders included in this category include mood dysregulation disorder, major depressive disorder, otherwise known as depression, and dysthymia. Now, obsessive compulsive disorders are next. And this category of disorders are, highly stigmatized and highly misunderstood. So obsessive compulsive disorders are a subtype of anxiety disorder where people experience obsessions and or compulsions. So you can have either one. So you can have obsessions and compulsions, or just obsessions and no compulsions, stuff like that. So obsessions are basically the irrational, involuntary thoughts, fears, urges, worries, or fixations. And in an attempt to neutralize the intrusive thoughts, a separate thought or action is done to try and reduce the anxiety or uncertainty. So that's the compulsion side of it. Now, there are two types of compulsions: overt compulsions, which are actions that are done outwardly and are visible to others, while covert compulsions are compulsions that occur within the mind. So this is another big misunderstood thing, is that these compulsions are, symmetry, or, the people that are super organized or something like that. But it can also be within the mind, and that's very important to remember when we're talking about OCD. Now, disorders included in this category include classic OCD, which have a lot of types of OCD within that. So you gotta keep that in mind, is that there's more than just the ones I'm going to talk about today here. There's hoarding disorder, trichotillomania, exploration disorder, and body dysmorphia. So those are just the main ones of this category. Now, the next one we're going to talk about is neurodevelopmental disorders. So this one can be kind of confusing, just because there's quite a few disorders in this category, but I'm going to try and explain just a few of them. So basically, the overall characteristics of these disorders are distressing symptoms beginning in early developmental period, often before you enter grade school, and are characterized by developmental deficits that impair personal, social, academic, or occupational functioning. So these disorders basically happen during childhood and early adolescence, and continue to develop over time. So disorders in this category include intellectual disability, communication disorders, language disorders, speech sound disorder, childhood onset fluency disorder, social pragmatic communication disorder, developmental coordination disorder, and stereotypic movement disorder. Now, we're just going to talk about a few here, a few of the more common ones, I'd say. So tic disorders are the first one that we're going to talk about, and they're characterized as sudden, rapid, recurrent, non-rhythmic motor movements or vocalizations, which are called tics. And these tics have an onset before the age of 18 years old. So there are 3 types of tic disorders included, and the most severe form being Tourette syndrome. And another misunderstood thing about this is that only 1 out of 10 people that are diagnosed with Tourette syndrome have a swearing tic known as coprolalia. So it's a lot less common than people think, especially like presented in the media. The media is always like, oh, Tourette syndrome is like the swearing disorder and stuff like that, but it really isn't. The next thing we're going to talk about is autism spectrum disorder. So autism spectrum disorder are characterized as a persistent impairment in social communication and social interaction with restricted, repetitive patterns of behavior, interests, or activities. Asperger's syndrome is no longer a clinical diagnosis and was integrated into autism spectrum disorder diagnosis. And surprisingly, 1 out of every 50 people are said to be on the autism spectrum, many of which are undiagnosed and unseeable by the typical eye. So this is another really misunderstood thing about these conditions, is that, autism, people think like it's something that you can see. It's visually easy to process and see somebody that is on the autism spectrum, but that's actually not the case. Many people are, just seem completely typical, but they're not able to regulate their emotions properly. They're not able to see how other people function properly. So there's deficits in that kind of thing, but it's more interpersonal. That's what we're going to talk about is ADHD. So ADHD is a persistent pattern of inattention and or hyperactivity. So again, you can have inattention and hyperactivity, or just inattention and no hyperactivity, and vice versa. So, and these patterns of behavior interferes with functioning or development. And another really misunderstood thing about this condition is that bad parenting does not contribute to the child having ADHD. So it's actually not how ADHD works. So specific learning disorders. So there are 3 distinct disorders within this category, yet many use them interchangeably, and you'll understand that in a second here. So dyslexia is a deficit in a reading comprehension rate, fluency, and accuracy. So that's the one that everybody thinks about right off the top of their head when they think about specific learning disorders, but there's also 2 more. So dysgraphia is the deficit in accurate grammar, punctuation, clarity, organization, and spelling. So when dyslexia is about reading, dysgraphia is actually about writing. And then there's dyscalculia, which is the 3rd one, which is the deficit in number sense, memorization, accurate, fluent calculation, and math reasoning. So dyslexia is reading, dysgraphia is writing, and dyscalculia is mathematics. Now, the next one we're going to talk about is trauma disorders. So trauma disorders, basically everyone experiences trauma differently, right? And everyone's subconscious coping strategies are never the same. What might have been a traumatic experience for one may not have been for another. So that's really a key point to keep in mind when we're talking about these kinds of conditions. So hypervigilance is a common symptom among these conditions and is defined as an enhanced state of adrenaline and sensitivity, which causes exhaustion. So disorders included in this category are post-traumatic stress disorder, or PTSD, acute stress disorder, adjustment disorder, persistent complex behavior disorder, and reactive attachment disorder. The next one we're going to talk about is eating disorders. So eating disorders can be characterized as having a body mass index of 19 or below, or 26 and above. One must experience a persistent disturbance of eating or eating-related behavior that results in the altered consumption or absorption of food, and that significantly impairs physical health or sociological functioning. So eating disorders are actually the most fatal mental disorders and are one of the most difficult to treat. This is because their brain's reward system is set off, similar to those with substance/addictive disorders. And this happens every time someone with an eating disorder carries out their eating behavior. Now, disorders in this category include pica, rumination disorder, avoidance/restricted food intake disorder, anorexia nervosa, bulimia nervosa, and binge eating disorder. Personality disorders are the next one. So these ones can be quite complex and difficult to understand, but I'm going to try and break it down as simple as possible to really better understand these conditions. So there are 10 types of personality disorders that are characterized or that are organized into 3 distinct clusters. So there's cluster A, cluster B, and cluster C. So a general personality disorder is characterized as a pervasive pattern of inner experience that cuts across all aspects of life. So of all of these conditions, including the personality disorders, they all cut across all aspects of life, from early childhood to late adulthood. That's typically how it presents. Now, one must be 18 or above to receive any of these diagnoses, as studies show that your personality is not necessarily fully developed until early adulthood. If an individual presents clear signs of any of these conditions, a specifier of early onset personality disorder would be signified in their diagnosis. Now, the first one we're going to talk about is cluster A. So cluster A is characterized by odd and eccentric thinking/behavior conditions. So a schizoid personality can be remembered as a seclusive person, as these people withdraw themselves from society and all social communication. And this is not due to social anxiety. So that's a key point to remember, is that this one is not about social anxiety. They just strictly are just super seclusive and not wanting that social interaction in their lives. So schizotypal personality, super fun to say, by the way, can be remembered as an eccentric person, as these people may seem out of touch with reality and completely abnormal in nature. So these people can be, think, they're from space, like they're aliens, or they may think that they're carrying baby Jesus in their womb and stuff like that. Now, paranoid personality can be remembered as a suspicious person. So these people may seem malevolent and almost trapped in a paranoid delusional state of consciousness. Now, cluster B are dramatic/unpredictable conditions. Now, antisocial personality disorder is the first one, and it's the equivalent to what most people think as psychopaths or sociopaths. Both those terms are outdated and are no longer used in the clinical setting. A violative person may not have any empathy for violating the rights of other living beings. Only about 50% of those in prison have this condition. So that's extremely important to remember, is that it's very common in prisons, but there's still the 50% that don't have this condition. Now, a narcissistic personality can be remembered as a manipulative person, and as these people may seek excessive admiration and approval from others without having respect or compassion for other people's feelings. Narcissists have very low self-esteem, which is the fuel for this manipulative behavior. So that's also really important to remember, is that, it's actually quite sad. These people have very low self-esteem, which is the reason why they're manipulative and don't know how to communicate properly to people. And it's quite sad, actually. So a histrionic personality can be remembered as a dramatic person, as these people may seek excessive attention and will feel unease if not in the center of attention. And the last one in this cluster is borderline personality disorder, which can be remembered as an unpredictable person, as these people have an ingrained fear of abandonment and excessive mood swings. So this is different than bipolar disorders, as the mood swings are more frequent and consistent. Because bipolar disorders are typically, their mood swings are typically weekly. So they change like every week or every 2 weeks and stuff like that. But bipolar, I mean, borderline personality disorder is more frequent. Now on to cluster C. These conditions are classified as anxious/fearful conditions. So the first one is avoidant personality disorder, and this can be characterized as the feelings of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. So think of this as like the severe form of social anxiety disorder. Now, dependent personality disorder is characterized as a pattern of submissiveness and clinging behavior related to an excessive need to be taken care of. Think of this one as the severe form of separation anxiety disorder. So obsessive compulsive disorder is the last one in all of these personality disorders. And it is characterized as a pattern of preoccupation with orderliness, perfectionism, and control. So basically the stereotyped type of OCD everyone thinks about. So it's a little more, it's a lot more rare than regular OCD, but it's the one that, most people think when they think about OCD. So it's kind of interesting that way. Now, psychotic disorders. So first we have to understand what is psychosis. So psychosis is when someone experiences either delusions or hallucinations and or disorganized thinking, abnormal motor behavior, or negative symptoms. So, you have to have either delusions or hallucinations, and you might have something in one of the other three categories, but you need at least the delusions or the hallucinations. Now, to better understand this category of conditions, we need to understand the types of symptoms. So there's positive symptoms, which you can remember it as like add abnormalities. So these are kind of the symptoms that add on someone's state of mind. So for example, delusions, hallucinations, disorganized thinking, derailment, tangibility, incoherence, grossly disorganized abnormal motor behavior, and catatonic behaviors. Then on the other side, there's negative symptoms. So these take away normalities, such as diminished emotional expression, prosody, and so on. They're on the screen there. Now, we are going to go into super quickly on the disorders within this category. So there's brief psychotic disorder, which is basically a psychotic episode, as this is a lot more common than all the other conditions in this category. Then the next one is delusional disorder. So this one is predominantly delusions, but hallucinations can be present in this condition, but they're due to the delusional theme. So anything that is considered a delusion would have to, considered a hallucination would play into the delusion, kind of the type of delusion that they're experiencing. Schizophreniform, another one really fun one to say, is the prerequisite to schizophrenia, as symptoms must persist for at least 3+ months. And then schizophrenia, on the other hand, is 6+ months of continuous psychosis. So the next one is schizoaffective disorder. Now this one, you can remember this one as kind of schizophrenia, but on top of that, there's a bipolar disorder. So it makes it a lot more complex and difficult to treat in treatment. And then the last one in this list is catatonia. So catatonia is quite confusing and difficult to understand, but we can maybe do a little bit more research later, or you guys can ask some questions later. So basically, catatonia can include stupor, cataplexy, waxy flexibility, mutism, negativism, posturing, mannerism, stereotypy, agitation, grimacing, echolalia, or echopraxia. Dissociative disorders. All right, so dissociative disorder is characterized as an intrusion into awareness, behavior, and the inability to access information or to control mental functions. So individuals with a dissociative disorder may either feel a detachment from themselves, which is called depersonalization, a detachment from reality, which is derealization, a detachment from identity, which we call alters, and then a detachment from memories. So this is dissociative amnesia. Dissociative identity disorder exclusively exhibits the detachment from identity, while the other types of dissociation have separate specialized disorders. So the word alter is used rather than personality to distinguish between the distinct states of identity. Multiple personality disorder was rightfully changed to dissociative identity disorder to represent the symptoms of the condition more accurately. So one with DID does not have different personalities, but in fact, during the early stages of development, fragments of one's identity was split into separate identities within them. So co-consciousness is a term used to signify that one with this disorder can be piloted by two identities at the same time. Those with DID are less likely to be violent than those of typical brain structures. So that's really important to keep in mind because like the media always presents people with multiple personality disorder, aka DID, that are very violent, but it's actually very super not true. It's just statistically not true. And so we're just going to talk a little bit about this diagram I have here. So the way that dissociation works and the way that the reason for it is that you're exposed to either a traumatic experience or a stressful experience, and then it goes into that kind of wheel. So you have the fight, flight, or freeze kind of notion of thoughts there. So flight would be kind of like panic attacks or psychosis, where your mind is trying to detach yourself from what is actually going on in your life, like the traumatic experience, the stressful situation. And then fight is more of like severe anxiety or impulsivity. So, you'll endure in that stressful experience or traumatic experience, but you'll experience really excessive anxiety or impulsivity. And then the one that everybody forgets is the freeze. So freeze is either dissociation or catatonia. So that's kind of an easy way to remember dissociation and how that works. So conduct disorders are the next ones we're going to talk about. So conduct disorder is characterized as behaviors that violate the rights of others, such as aggression, destruction of property, etc., and or that bring you into significant conflict with societal norms or authority figures. Now, the first one we're going to talk about is oppositional defiant disorder, which is basically when someone has a frequent pattern of behavior presented as angry or irritable moods, argumentative defiant behavior, and vindictiveness. And the second one in this category is intermittent explosive disorder. So a person with this disorder has frequent impulse, aggressive, angry outbursts. These can be verbal or physical aggression towards property, animals, or other people. So basically, the difference between that one and this one would be that oppositional defiant disorder is more of a pervasive pattern. So, you have it more frequently, but it's more like a long-term thing. And then intermittent explosive disorder is more of like angry outbursts of episodes of rage and impulsiveness and that kind of way. So you can kind of remember it like that. And then there are three more conditions in this category. So there's conduct disorder, which is basically the prerequisite to antisocial personality disorder, or like psychopath, sociopath. Those are outdated, remember? So yeah. And there's pyromania, which you can remember that as like arsonists. And then kleptomania, which is you can remember that as like shoplifters. But you have to keep in mind is that pyromaniacs and kleptomaniacs, they don't. It's really hard to explain, but they don't necessarily want to. They're compelled to do these behaviors. They're compelled to do these actions, and you can't really give that excuse for someone's actions. But it gives us a unique way to see how our brains are structured and how our personalities intertwine with society norms and things like that. So it's actually very interesting. Bipolar disorders are next. So to meet criteria for bipolar disorder, one must experience depressive episodes and either manic or hypomanic episodes. So before we understand bipolar disorders, we have to go into these types of episodes. So depressive episodes are a period of depression that persists for at least 2 weeks. So that includes, tiredness, changes in appetite, hopelessness, etc. And then there's manic episodes, which are uncontrollably elated or energetic states that may last for a week or more, and typically ends in hospitalization. And then hypomanic episodes are a less severe form of mania that lasts for a week or more, but does not typically end in hospitalization. Now, there are three conditions in this category. So there's bipolar 1, bipolar 2, and cyclomania. So bipolar 1 is basically when someone meets criteria for a manic episode and a depressive episode. Bipolar 2 is when someone meets criteria for a hypomanic episode, but does not meet criteria for a manic episode, but they also meet criteria for depression. And then cyclothymia is kind of in between the two. So one has to meet criteria for a hypomanic state, but they don't necessarily meet criteria for a depressive state. Somatic disorders are next. So somatic disorders are associated with significant distress and impairment. It is common for patients to visit a primary care physician and other medical settings, yet symptoms do not decrease over time. So that's kind of an easy way to remember these ones, is that, people go to these medical settings and physicians and doctors, and their symptoms don't decrease over time. Now, faking a mental illness is actually extremely uncommon. And there are two types of disorder categories which consist of unintentionally faking mental illnesses, which is malingering and fictitious disorder, and three types of faked conditions that are unintentional. So there's intentional and then unintentional. So the unintentional ones are somatic symptoms, illness anxiety disorder, and conversion disorder. So we'll go through them one by one really quickly and just kind of differentiate the two, or the different conditions. So conversion disorder is a condition in which you have physical symptoms of a health problem, but no injury or illness to explain them. So basically, your body can convert the emotional and psychological stress into a physical response. And, it might seem strange, but these symptoms are real and one does not control them. Illness anxiety disorder, on the other hand, previously known as hypochondria disorder, is where people experience anxiety around getting ill. So people may check their body for signs of illness and think that a normal body blemish is a sign of a serious illness, or that a slight sensation could mean that they're going to die or something like that. No, it's very, very debilitating. Then there's somatic symptom disorder, which is characterized by an extreme focus on physical symptoms, such as pain or fatigue, that causes major emotional distress and problems functioning. The one experiencing a somatic symptom may or may not have another diagnosed medical condition associated with these symptoms, but the reaction to the symptoms are not normal. It's important to note that those experiencing these symptoms are not intentionally faking their symptoms. Then you have malingering. So malingering is the fabrication or exaggeration of physical or sociological symptoms designed to achieve a desired outcome, such as relief from duty or work. So malingering is not a medical diagnosis, but may be recorded as a focus of clinical attention or a reason for contact with mental services. Now, fictitious disorder, is previously known as Munchausen syndrome, is a serious mental illness in which someone deceives others by appearing sick, by purposely getting sick, or by self-injury. So fictitious by proxy is kind of a subtype of that condition. And this is when a family member or caregiver or someone, in authority falsely presents others, so like as yourself, such as children, as being ill, injured, or impaired. Parents may purposely poison their child for convenience, or convince their child, that they have a serious illness in order to get attention while caring for the child. Neurocognitive disorders. This is another category of disorders that can be very complicated, but we're going to kind of break it down super simple. So all of these disorders in this category can be described as distressing symptoms that are acquired rather than developmental. So they're kind of the complete opposite of neurodevelopmental disorders, and that you typically get them later in life, but it is possible to get it earlier in life. Now, the first one is delirium. So delirium is a serious disturbance in mental abilities that results in confused thinking and reduced awareness of the environment. This is caused by severe or chronic illness, changes in metabolic balance, medication, infection, surgery, or substance intoxication or withdrawal. And then there is major and mild neurocognitive disorders, which are characterized by a significant decline in neurocognitive intelligence and are typically a result of one or more of the following diseases. So these diseases on the right-hand side here, so Alzheimer's, you have HIV, even traumatic brain injuries. It can also be caused by substance/medication induced, Huntington's, Parkinson's, Peyronie's diseases, all of those on the right there. So they basically cause this neurocognitive decline. It can be very scary, but yeah. So we're going to talk a little bit of what the difference is between dementia and Alzheimer's, because I feel like a lot of people get these two terms confused. So dementia is an outdated term now, used to describe a neurocognitive decline. So we use the terms major and mild neurocognitive disorders instead, as it more accurately represents and simplifies the conditions. It is an umbrella term consisting of all the diseases listed on the right of the slide here. So Alzheimer's is a specific disease in which causes a neurocognitive decline. And then the next one we're going to talk about is sleep-wake disorders. So sleep-wake disorders can be characterized as difficulty initiating sleep, maintaining sleep, inability to return to sleep, or physical sleeping complaints/difficulties. So this is another category that can be very difficult to understand because there's actually lots included in this category. But we're going to break it down into three different distinct clusters again. So there's sleep-wake initiation disorders, which are the first domain and include insomnia disorder, hypersomnolence, narcolepsy, and circadian rhythm sleep-wake disorders. So the next domain is breathing-related disorders and include obstructive sleep apnea or central sleep apnea and sleep-related hypoventilation. So then the third one is parasomnia. So parasomnias are the third domain and include non-rapid eye movement sleep arousal disorders, nightmare disorders, REM sleep behavior disorders, and restless leg syndrome. So we're just going to talk a little bit about narcolepsy because this condition is very highly stigmatized and very interesting and fascinating to dive into. So basically, narcolepsy is a chronic sleep-wake disorder characterized by overwhelming daytime drowsiness and sudden sleep attacks. A simplified way of viewing this condition is that normal people have a distinct separation between the sleep phase of consciousness and the wake phase of consciousness. But the brains of those suffering with narcolepsy have a blurred sense of the different phases. Those without narcolepsy take approximately 90 minutes to enter REM sleep, which is the deepest state of sleep, while those with narcolepsy can enter REM sleep in just 5 minutes. It's very fascinating. And those with narcolepsy describe the chronic daytime drowsiness as almost feeling stuck in a drunk sedative state all the time. This may seem like a superpower, but I want to highlight as to why it is truly a disorder and not a superpower. So cataplexy is a common symptom associated with this disorder and is characterized by a loss of muscle tone. Let me explain what that means further. So when you fall asleep, your brain temporarily paralyzes your body so that you do not carry out the actions in your dreams in real life. But those experiencing cataplexy may randomly experience specific paralysis or even full body paralysis while still being conscious. So they have these, some even have these hallucinations, which can happen right before someone falls asleep. And this is another common symptom of this condition. Narcoleptic sleep attacks can happen so suddenly that it can be extremely dangerous in many situations, such as driving a car or being alone in public. And strong emotional sensations can instantly trigger these sleep attacks, such as excitement or fear, which is, of course, can be very dangerous in any such situation, really. Now, one of the last ones we're going to talk about here is substance addictive disorders. So these conditions can be described as an intense activation of the reward system caused by a substance or activity in which normal events may be neglected or negatively affects one's daily life. So substances and addictions included in this category include things like gambling, alcohol, caffeine, cannabis, hallucinogens, stimulants, inhalants, opioids, tobacco, sedatives, hypnotics, and analytics. And typically, these symptoms can be differentiated between substance use, substance intoxication, and substance withdrawal. So we're just going to go through what that actually means. So substance use disorder is the persistent use of a substance despite substantial harm and adverse consequences in someone's life. And then, so a substance intoxication disorder, on the other hand, is a transient condition of altered consciousness and behavior associated with recent use of a substance. It is often maladaptive and impairing, but reversible. If the symptoms are severe, the term substance intoxication delirium may be used in a diagnosis. So a substance withdrawal disorder is a group of symptoms that occur upon the abrupt discontinuation or decrease in one's intake of a substance. So that's the withdrawal. So due to time constraints, as well as mature subject matters, we will not be discussing sexual dysfunctions, paraphilic disorders, and elimination disorders, as well as gender dysphoria. So nevertheless, these disorder categories are in fact included in the DSM-5. So I just wanted to highlight that, they're there, but we're not going to necessarily talk about them today. So we just have a few unrecognized disorders. So there may be unrecognized disorders not included in the, there are many unrecognized disorders not included in the DSM-5, but I would like to discuss just two of them that come to mind. Now, PANDOS stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with streptococcal infections. And PAN stands for Pediatric Acute Onset Neuropsychiatric Syndrome. PANDOS/PANS are neuroimmune disorders. This basically means that the immune system attacks part of the brain called the basal ganglia that is responsible for behaviors, movement, and cognition, and emotional regulation. So when this part of the brain is attacked, it becomes inflamed, leading to an onset of complex neurological and psychiatric symptoms. These conditions are typically triggered by streptococcal infections, but can also be caused by other diseases such as mycoplasma, pneumonia, Lyme disease, influenza, and more. So studies are still being done on the effects of COVID-19 on the brain, but in theory, COVID-19 can also cause PANDOS/PANS syndrome. And the last one we're going to talk about is pseudobulbar effect. And this is where people have inappropriate and excessive involuntary outbursts of laughter or crying, and/or crying. This is a symptom that can occur in a variety of neurological conditions, such as, Alzheimer's disease, ALS, dementia, Huntington's, Parkinson's disease, multiple sclerosis, and PANDOS/PANS syndrome. It can also occur in stroke survivors, nevertheless. So these may also be known as emotional lability or emotional incontinence. And this condition can often be mistaken for other conditions such as crying related to a mood disorder or laughing due to a tic disorder. But in fact, it is slightly different in the way that it presents itself among other neurological symptoms. So an individual experiencing pseudobulbar effect might experience an extremely sad situation, but involuntarily begin to excessively laugh or encounter a minimally sad situation and involuntarily excessively cry for an excessive amount of time. And yes, this is just one of the conditions that the Joker from the DC universe would be suffering from. So yeah, this is a time for any questions here. And this is the QR code that I promised at the beginning. So I really encourage everyone to, either to screenshot it or scan the QR code so that you can, and then fill out that quick form online, and you'll be sent an email with all the information, resources, and everything that we talked about today. And yeah, thank you for watching.